Hi, my name is Madeline Ravy. I am a student in the undergraduate program at Cal State San Marcos, and today I am going to be talking about cleft lip and or cleft palate and abnormal resonance. And I want to apologize ahead of time. For some reason, the present button won't work on my computer, so I will just have to present like this today. So I hope that is okay. Let's get started. So, in order to understand what cleft lip and or cleft palate is, we need to define what cleft is. So, a cleft is when something is partially or completely divided into two. So now we are going to get in the difference between cleft lip versus cleft palate. So with cleft lip, you can see that it can either be unilateral. This is where the cleft will only be on one side. It can either affect the left side of the upper lip or the right side. Also, there can be a bilateral cleft lip, and this is where the cleft will be on two sides. It can also be incomplete, and you can see there is a cleft right here, but it's not going up all the way to the nose. Also, there is a complete cleft lip, and you can see it's going up all the way to the nose. Now we are going to get into cleft palate. It can either be incomplete, where it's going from the hard palate to the premaxilla, or it can be complete, and you can see that it's going from the hard palate to the lip. And I forgot to mention that cleft lip and palate, they can either occur by themselves or they can occur together. There is also what is called submucous cleft palate. And you can see this is where there is separation of those tissues in the palate. So you can see this blue discoloration right here. That is called the zona pellucida. Also, during an assessment, a speech pathologist can feel for a bony notch at the end of the hard palate. Also, on the right, you can see that there is a bifid uvula where the uvula is split into two. And these are three things that a speech language pathologist will look for while doing an assessment. And the interesting thing about the submucous cleft palate is that sometimes it will affect the person's speech production, but sometimes the person can live their life without their speech ever being affected. But of course, this is something that the speech language pathologist will always look for when doing an oral mechanism exam. So there are some interesting trends when talking about cleft lip and cleft palate. 10 to 15% of individuals, this is regardless of whether the person also has cleft palate or not. 10 to 15% of individuals with cleft lip will have a related syndrome. With cleft palate only, however, 40 to 50% of individuals will have a related syndrome. This can be like Treacher-Collins or Apert syndrome. Also, with cleft lip, it happens twice more in males than females. But with cleft palate, however, this happens twice more in females than males. And many people wonder why this is. Well, it has to do most likely with differences in female and male development. So, with cleft lip in males, the secondary palate right here during male development will close first. So, that leaves the premaxilla to the lip the primary palate open longer. So this could be why males are more prone to developing that cleft lip. However, with females, that primary palate will close first, leaving that secondary palate right here open longer. So this could be a reason why females are more prone to developing a cleft palate. So here are some causes of cleft lip and or cleft palate. With maternal health, maybe there's an infection in the mother that might transfer over to the baby. Environmental teratogens, alcohol is a huge one. Mechanical factors can happen in utero. Genetics, again, we talked about how some individuals with cleft lip and cleft palate might have a related syndrome. Also, delays in cell migration that might affect the development of that primary and secondary palate. And also, of course, there are just causes out there that we do not know of and do not know why that happened to the child. So the cleft lip and or palate team, the speech language pathologist is not going to treat a cleft lip and or palate alone. This is a multidisciplinary approach. This can involve the orthodontist, cleft surgeon, speech pathologist, ENT. Psychologist is an important one. Unfortunately, there are cases where children do get made fun of in school. So again, it's really emphasizing those professionals are working together with the child. So now we are going to talk about how cleft lip and or palate can affect resonance. So to define resonance, this is how sound is shaped in the oral, nasal, or pharyngeal cavities by the generation of the vocal folds. And also the functioning of the velopharyngeal mechanism will affect resonance. So now for abnormal resonance, hypernasality is one. This is where there is too much sound resonating in the nasal cavity. This is not very common. You're pretty much only going to see this in individuals that have cleft palate, or there might be something wrong with their velopharyngeal mechanism. Also, with cleft palate after surgery, sometimes the child can develop a fistula, so that certainly can also cause hypernasality. Oftentimes, children will substitute consonants for nasal, so they will say the for the b sound and the for the d sound. The opposite of hypernasality would be hyponasality. This is when there is too little sound resonating in that nasal cavity. So the child might say the b sound for the sound or the d for the n sound. And this is actually more common. You might see this with a person that has a cold, maybe a sinus infection, and their nose is just going to be all clogged up. So there is cul-de-sac resonance. And I can't really mimic this one, but this is when sound is trapped in a cavity and it cannot escape. I have a YouTube video here if you want to watch it of this girl who does have cul-de-sac resonance. And it's very hard to hear the person because their voice will sound very muffled and low in volume. You can often see cul-de-sac resonance with a person that has enlarged tonsils or maybe a smaller oral cavity than usual. Something else important to mention here is nasal air emission. I want to make it clear that this does not have to do with resonance. Resonance is only the acoustic property of sound. Nasal air emission is when there is too much air pressure in that nasal cavity. This is often going to occur with voiceless sounds, especially those fricatives, so the sh sound and the f sound. This will affect the child's articulation. Again, does not have to do with the resonance. And I'm not talking about assessment really in this lecture, but you can see here, this clinician is providing the child with a mirror test. And you can see here that if they do have nasal air emission, it will fog up this little mirror right here. So I thought that would be interesting to share. Thank you so much for listening to my presentation today. I hope you found it to be helpful and informative.